Okay, Assalamualaikum and good morning everyone. I hope everybody can see my slide.
Ya, Doktor?
Boleh nampak slide kan?
Boleh.
Alright, moving. Okay, alright. Thank you very much to the our MC today, Dr. Rahimi, and thank you to the MSO and MMA for organizing this course in which with the title The Art of Seeing Basic Ophthalmology for Primary Care Providers. So as the first presenter, my topic today will be basic eye examinations, and I'll try to present it so that this topic, this 30 minutes lecture will be beneficial for you all. Alright, so these are the outline of my presentation in which I'll cover a bit on the basic anatomy, indications for eye examinations, some basic tools, and a simple systematic 5-minute approach with case examples. Okay, before we move further to the eye examinations, let's recap a bit on the basic anatomy of the eye. Alright, looking here, there's nothing new. Basically, you can see the upper lid, lower eyelid with the eyelashes on the upper and lower lid as well. And the iris and pupils is actually two structure that controls the light to goes into the retina. Alright, and this limbus is actually a very important structure. Limbus is actually an area, the junction between the conjunctiva sclera with the cornea. The cornea part is actually the transparent in front of the iris and in front of the iris. Okay, so the white part of the eye, most of you will call it as sclera, but sclera is actually the underneath part, the overlying, alright, is a transparent layer that we call it as conjunctiva. And at the middle canthus here is the caruncle, a structure that you have to look for in terms of inflammation or redness in the case of thyroid eye disease. Okay, so if you look at the eye in the cross sections, we can see that the eye is divided into two chamber, all right, two segment, anterior segment and posterior segments, which is bordered between that two segment by the lens. Okay, all right. So we have aqueous humor in the anterior chamber, whereby at the posterior segment we have vitreous humor. So the aqueous humor lens and the vitreous should be clear so that we can see clearly. All right, and not only that, in order for us to have a good visions, the retina as well as the optic nerve also must be healthy. Alright, so when we look further on the retina, three important landmark is which is the optic disc, macula, and fovea centralis. Okay, apart from this, we actually look into the vessels because as you all know, the only organ in the body that we can see the nerves as well as the vessel is only the eye. Alright, the nerve is actually the optic disc, that is the cranial nerve 2, and the vessels. Alright, so in the case of you suspect patients to have any problem with related to diabetes or hypertensive, but you are not very sure whether the patient is newly diagnosed or could it be due to something else, you can send the patients to ophthalmology for a proper assessment for us to identify whether there is presence of any diabetic or hypertensive retinopathy. Alright, and it is not new. Most nephrologists always refer the cases to us to assist them in evaluating patients with kidney failure. Alright, so the eye is not just the eyeball. Alright, you have to know a little bit on the related structure to the eye. As I put here, it's like a cross sections of the nose where you can see the nasolacrimal duct connected to the eye via the canaliculus and the punctum. And this nasolacrimal duct is actually the drainage organ ataupun the drainage part for the tear for the tears. So the lacrimal gland, which is situated at the superior-temporal aspect of the eye, all right, within the eyelid. Okay, this is the main tear gland production. Okay, so if you look at here, this is the bony orbit, where our eyeball is situated. All right. Why I put it here is because the relations and the importance in term of trauma-related injury, okay, or perhaps some cancer involving the bones. All right. And not only that, the eyes, our eyeball um, is actually connected to the movement of the eyeball is actually by our extraocular muscles. Okay, as you know, we have 4 recti muscles and 2 oblique muscles, and these muscles are innervated by the 3rd, 4th, and 6th cranial nerve. Okay, so in the case of patients having diplopia, double visions, the problem sometimes is not within the eye, it's not within the eye or within the retina, but it arises from the intracranial lesion or intracranial pathology. Okay, not only that, surrounding the eyeball within the orbit is actually a lot of orbital fat, and this orbital fat can become inflamed in the case of orbital cellulitis or in the case of thyroid eye disease. And in the case of trauma, patients might have retrobulbar hemorrhage, and all these pathology or inflammations can compress on the extraocular muscles as well as the optic nerve. And our eye is actually a continuations of the brain as well. Okay, so we cannot see without the connections between the eye optic nerve, which decussets into the optic tract and then goes to the radiations before they goes to the occipital cortex. All right, so why I showed you all the relations of the eye to the other structures, because most patients presented with eye complaint or visual complaints, they are not having the eye problem mostly. Okay, some may have, but some may not. All right, so why basic eye examinations matters? You don't need to be an ophthalmologist to save visions. The indications for eye examinations include perhaps routine physical examinations and eye screenings. Okay, and you can perform eye examinations in those patients presented with blurred vision, eye redness, diplopia, visual field loss, or perhaps any injury to the eyes. Okay, and apart from that, screening for end organ damage is very important in the case of patient with diabetes and hypertension, because you want to see whether they have retinopathy or not. And apart from that also, we screen, you can screen the eye, refer the patients to us to assess for the adverse effect or toxicity of certain medications such as ethambutol, steroid, or hydroxychloroquine. Okay, so what are the basic equipments for primary care providers? We don't expect you to have a lot of equipments or tools, but these are the basic one. All right, Snellen chart. All clinics basically have Snellen charts, and with Snellen chart, you need to have occluded and pinhole, all right? And then you need to have pen torch, and preferably the one with the yellow light, because yellow light has good concentration, more soft and more gentle to the eye compared to the white light. All right, and then Ishihara plate, which is for color vision test, also very important. And you need to have a simple target. So simple target can be your penutup pen, or perhaps some anything 3D that you can use. Perhaps you can put some stickers on the tongue depressor. You can use it as simple target as well. So these are the basic minimal equipments for you all. All right, now we move on to the basic eye examinations. You don't need to spend a lot of time to examine the eye. Okay, 5 minutes. You just need to spend 5 minutes, okay, to accomplish the 5 essential components. So the first one, you need to perform the visual acuity. All right. Second one, external and anterior segment examinations. Proceed with pupil examinations, and then perform the extraocular movement as well as the visual field by confrontation. So this structured approach of basic eye examinations will help you detect the most dangerous eye conditions or sight-threatening issue early, and perhaps you might able also to detect some life-threatening conditions. All right, the visual acuity assessment. Perhaps around 1 minute to spend on this. So visual acuity is the vital sign of the eye, and it should always be done first. Okay, and you need to ask the patient to wear their glasses if they are on, okay, if they have glasses. So this visual acuity usually done for distant vision. So perhaps the distance between the Snellen chart and the patient is 6 meter. And if vision is less or worse than 6, you need to use pinhole. Patients presented with sudden reduced vision acuity, you need to treat it as red flag. Even if the eye looks normal, even the eyes is perfectly white. Okay, because it may be sight-threatening conditions involving the optic nerve, such as optic neuritis, or perhaps patient having retinal detachment or central retinal artery occlusions. Okay, how do we assess visual acuity? Basically, if you look at the Snellen chart, the topmost line is 660, all right? But the 66 vision you need to check properly because some Snellen chart, the lowermost could be like 64.5, something like that. So you need to check properly. So you need to perform the visual acuity for right eye and left eye separately. Perform pinhole if the vision worse than 66 and if patient unable to read 660, all right? 660 letter, which means the topmost letter at 6 meter distance, you have to move patients 1 meter forward till the patient can see. So the vision will be 560, 460, 360, 260, and 160. That 5, 4, 3 to 1 is actually the distance from which patient can see the topmost line. All right. But if patient still unable to read 160, all right, means at 1 meter distance, patient still unable to look at the topmost line. So you need to perform finger counting test. All right. But then if patient still cannot count finger at 1 feet distance, you need to test for the hand movement. If vision is worse than hand movement, please perform the light perception test and vision could be PL or NPL. All right. And not only performing the test is important, you have to know how to correctly document the vision as well. Because this visual acuity is actually medical legal, all right? Most of you, most of the patients will present to you first, okay, for whatever reason, for whatever complaint. So the vision from your side is very important. Okay, this is the example such as right eye, the vision is 618. So vision is less than 66. So we perform pinhole. Pinhole is 69. And this patient is wearing glasses. So we write here with glasses. If patient is not on glasses, means no refractive error at all, no need to write. But if patient has refractive error and wearing glasses, but at that particular time, they didn't bring the glasses, so you need to write there without glasses. Okay? Okay, so the visual acuity assessment can be assessed by Snellen chart. Okay, the standard one is the one with the letter. All right, but if in the case of patients who are not able to read or perhaps kids, you can use this tumbling E chart or Land.C chart. Okay, I'm sure every clinic also have this one. Right. We finished with visual acuity. Now we move on to the external and anterior segment examination. This one also you need, the most is like 1 minute. All right. So what you need to do? The first one is general observation. So basically you observe the patient generally from the eyelid. Okay. Look for any asymmetry, whether there's any ptosis, mass, or any fullness, edema, or redness. And look for squint and as well as proptosis. And to perform this, you need torchlight. All right. So what is this torchlight examinations? It is actually very useful to examine the external condition, and you can also perform anterior segment examination using the torchlight. And apart from that, these torchlight examinations also, you can accomplish the pupillary examinations later. And with this also, you can assess the corneal light reflex to check for ocular centration. Means you want to confirm whether there is squint or not. Okay. All right. But the torchlight must be well lit and functioning one. So what you can see during external eye examinations, usually patient won't come to you. Patient will come to you complaining of perhaps some fullness or redness. And these are the examples. So on the left one here, patients having proptosis in the grave disease, patient with hyperthyroidism. But let me tell you, because some patients, sometimes they are in hypothyroid status or euthyroid, but they can still present with these conditions. Okay, and On the right one is actually patients. Look at the center image where you can see the right eye is actually squinted, it moving inward. And if you look at the whole 9 gaze, the finding is actually consistent with right cranial nerve 6 palsy, and this is actually real case of herpes zoster ophthalmicus with cavernous sinus extensions. So if you see the herpetic lesion is very minimal, but the lesion is actually, let me enlarge a bit. You can see the herpetic lesion is actually involving the tip of the nose. So in any cases with herpetic lesions, whether it is minimal or a lot, and it crossed the nasal bridge or affecting the tip of nose, you need to think of intraocular involvements, and you must refer to Opthal. Okay, then these are the other examples. We have here complete ptosis, partial ptosis, which is the drooping of the eyelid. And on the lower image here is actually fullness of the left upper lid. Okay, it may look normal, but if you compare to the other eye, you can see some asymmetry, and you can tell it as a fullness of the left upper lid. And let us see on the right image here, where you can see both. This patient has upper lid fullness, also puffiness on the lower lid with right partial ptosis. So this patient is actually having thyroid eye disease. All right. So thyroid eye disease not necessarily to be red eye. Okay. So patients might have some ptosis or some movement restrictions of the eye. So this patient is actually having limitations of the eye movement, and he also having some proptosis, but not very evident in this one. And apart from that, on eyelid examinations, you can also identify patients having preseptal cellulitis, orbital cellulitis, chalazion, or perhaps this scary looking condition, which is lid abscess secondary to chronic recurrent infected chalazion. And this is another example of herpes zoster ophthalmicus. Just now I showed a very minimal lesion, and these patients have very severe extensive lesion. So in these kind of cases, you need to refer to us because we have to examine the optic nerve function as well, because the risk of optic nerve extension to the optic nerve as well as intracranial, okay, is very, very high. And on the right image is middle canthal swelling. All right, so you can see the middle part of the eye is actually swollen, involving the lower lid as well. This is the case of acute dacryocystitis. Okay, and apart from that, on anterior segment examinations, what you can find is such as conjunctival congestion. This one Dr. Ain will tell you all later. All right, and then we have also subconjunctival hemorrhage, and this is conjunctival chemosis, which is the edema of the conjunctiva. So on anterior segment examinations, if you look on the cornea, you might see if you shine. If you don't shine, you may miss it. That's why pen torchlight examination is very important. So when you shine it, you can obviously you can identify this haziness. All right. Okay, and on the upper image here, you can see some hypopyon, the whitish pus within the anterior chamber, and the beneath one is actually blood in the anterior chamber, which is hyphema. And the last image here showing patients having endophthalmitis with full of pus within the eye, anterior chamber. So not only that, on anterior segment examinations using pen torch, you can assess the anterior chamber depth as well. All right, and this is actually the simplest method where you shine the pen torch into the patient's eye from the temporal limbus. So like in the picture here. All right, so you have to grade accordingly. The basic rule is that if the eye is fully illuminated with these temporal illuminations, means the angle, the anterior chamber is open. All right. Whereas if the light is only partially, very minimal, illuminating the anterior chamber, okay, as shown here in the picture, okay. All right. It is grade 4. Sorry, it is grade 1. So grade 4 is actually the wide open. Grade 1 is actually the shallow angle. Right. Now we move on to the pupil examinations. So let's have a look at this one. For pupillary examinations, you need to assess 3S, which is the symmetry, size, as well as the, sorry, what is another shape, okay? So basically, the first one just now, we shine the eye from below or from front, and then we are comparing right and left. And then after that, we check for the direct. So for direct reflex, we will test from temporal, and then we move on to the other side as well. And the last one here is our APD assessment. Okay, this is our APD assessment. So during pupil examinations, you need to think, are the pupils equal? Do they react to light? Do both eyes react the same? Okay, and apart from that, is there RAPD or not? It's okay if you don't elicit it, as well as you can identify there is an isochoria. You may refer to us for the next step of evaluation, because RAPD sometimes can be difficult to assess. All right, so, and what is anisocoria? This anisocoria is unequal pupil size. So a difference of 1 millimeter or more is considered abnormal. So within 1 millimeter is physiological, more than 1 requires assessment. So any anisocoria more than 1 millimeter with symptoms, patients need urgent referral. So a weak or slow reaction in one eye means the patient's having optic nerve problem. If the pupil is big, non-reactive, it could be sign of surgical third nerve condition. All right, can be due to PCOM aneurysm. All right, and if the pupil is small, not dilating in the dark, all right, it may indicate Horner syndrome, but you have to assess another symptom of it also. And if, let's say, patients having dilated pupil, complaining of pain, and having cloudy cornea, these patients might have acute glaucoma. So when do we need to refer anisocoria? If it is new onset, if it is associated with ptosis or diplopia, if associated with headache or pain, and it is worse in bright or dim light. Okay, so we need to think whether the problem is with sympathetic or parasympathetic. And if the anisocoria develop after trauma, and in the case of suspected Horner or cranial nerve third palsy. All right, so this is a busy slide showing normal RAPD, okay, normal pupillary light reflex, and then presence of left RAPD and no RAPD, but I will not cover this one. Like I said earlier, as long as you can detect the anisocoria, that one is good enough. Okay, now we move on to the red reflex, because you can also assess red reflex during using the pen torch. So this red reflex is actually reddish orange or yellowish glow from the retina. So very fast and reliable, and you have to do it in pediatric patients, as well, especially babies, and in those patients who have trauma, patient diabetes, and those come with sudden vision loss. Okay, so how to check? You need to shine a light from one arm length right into both eyes. You need to dim the room so that you can see the glow clearly, because we are Asians, so we have brown or dark colored iris. Our red reflect is not really red. Okay, so you need to really remember of this. So it's not necessary to be red, but it should have that at least orange or yellowish glow. All right, and you need to observe if both eyes having showing symmetrical or asymmetry red reflex. So normal is bright, equal glow in both eyes, whereas abnormal can be absent or reduced, or unequal reflex, or perhaps leukocoria. So leukocoria in pediatric patient, you need to suspect retinoblastoma. In other age group, the absent or reduced reflex could be due to cataract, corneal opacity, vitreous hemorrhage, or in certain cases could be due to retinal detachment. So some patients having unequal reflex, it could be due to refractive error or strabismus. This is the example of it. Okay, these are collections of leukocoria in babies. All right. So if you see here, It is white. This is a normal one. There's no glow here. That's why it is called leukocoria. It's white. Instead of glow, it appears white, as well as this one. All right. And this one as well. All right. And this one as well. Why in these patients it doesn't appear very bright? Because sometimes they don't use retinoscope and just use torchlight, so the glow is actually a little bit different. Okay. All right. So in this one, you can actually see red reflex here, and this is a clear leukocoria in the left eye. Okay, we move on to the extraocular movement. For this, you only need 30 seconds. All right. So how you do it? You need to ask patient to follow your finger in H patterns. Okay, you can do H pattern, you can do cross pattern. Okay, but whatever it is, you need to know what you are assessing. So you need to ask the patient, do you see any double anywhere? Okay, and is there any pain on movement? And you have to check if the movements are smooth and complete, or it is restricted, or perhaps the movement can be slow, stiff, or less coordinated in Parkinson. All right, in certain patients, Parkinson's, they don't have this bradykinesia yet, but they can present to you with diplopia. All right, and sometimes it is difficult to assess because their eye movement is pretty different from the usual cases. Alright, so both upper lids must be lifted on assessing the downward gaze. Please remember this one because like in the video just now, okay, you can see, because for the purpose of this video, I didn't lift the upper lid, but in clinical cases, in real patients, you need to elevate so that you can see the full movement of the eye on down gaze. All right. So the last step of extraocular movement is that you can test for accommodation, the convergence. All right. So in accommodations means the eye move to the center, converge. All right. The pupil will be minus, getting smaller, and there is increase in the anterior posterior diameter of the lens. All right, for you to focus. So why this extraocular movement important? Okay, extraocular movement is particularly important to do if patient presented with diplopia. Alright, but some patients, they don't have diplopia because one eye already have poor movement. That's why you have to know the vision first before you proceed with extraocular movement. Okay, so if in the cases of normal patient deny any diplopia, but one eye is actually hand movement, counting finger or PL, that explain why patient doesn't have diplopia even though have EOM restriction. So a new onset diplopia, all right, usually due to limitations of eye movement, the third, fourth, sixth under this nerve innervation, sorry, either isolated or in combination. So it could be due to some diseases related to inflammation such as thyroid eye disease, or it could be due to conditions such as myasthenia gravis, okay, or it could also be due to medical causes such as patient with hypertension or diabetes who have this we call it as mononeuritis simplex, in which the inflammation is affecting the single nerve. So if there is painful during EOM test, it could suggest scleritis or any orbital disease and perhaps optic neuritis as well. All right. And in some cases, patients come with diplopia, but upon assessing EOM, you you cannot elicit any restriction. So in this case, do not assume that patient is making up symptoms or whatsoever. Please refer to us, okay? Because we have a few other tests to do to assess the EOM as well as to assess why patients complain of diplopia. Could be due to EOM limitations or it could be also due to refractive error. Okay, and other than that, you need to assess EOM in all cases having head trauma to see whether any possible fracture. And the last one, confrontation visual field test. This one take about 45 seconds to 1 minute. All right, a very simple test but very powerful screening tool to assess any intracranial pathology. All right, in the case of stroke, patients will have contralateral hemianopia. In the case of pituitary tumor, patients might have bitemporal loss. In the case of optic neuritis, due to any causes such as optic neuritis or perhaps ischemic optic neuropathy, the visual field loss can be variable. It can be central scotoma. It can be visual field defect affecting the central, continuous with the blind spot, as well as attitudinal loss, whether superior or inferior. And apart from that, in the case of papillary edema, all right, you can also elicit enlarged blind spot in these patients. So to assess this visual field, the visual acuity must be at least counting finger or hand movement. So how you do it? You need to cover basically what we do in Opthal a little bit different, a little bit detailed than you need to do. But don't worry, just perform the usual one, all right, in which you need to cover all four quadrant, the upper temporal, the upper and lower temporal, as well as the upper and lower nasal. So you need to cover patient's eye, and then you need to cover your eye as well. All right, so you are comparing your visual field, the patient's visual field with your visual field. Most important is that you need to sit directly opposite the patients, okay, and at the same eye level. Patient should always maintain fixations on your nose or on your eyes. Either way is okay, as well as patient is fixating. And what you need to do is that just wiggle your finger or move some object from the periphery toward the center and ask the patients to see when you first see my fingers. And repeat on the other eye. Okay, so like I said earlier, our Opthal assessment is a little bit detailed. All right, so the first one just now, I was assessing the vision. Okay, eliciting the vision must be counting finger before proceeding. So the first one just now, after that, I was asking the patients whether he can see my face or not. All right, and then following that, I asked patients whether he can see my finger, how many of it. And the last part here is actually assessing the peripheral. Okay. So the basic documentation that you need, all right, is just this for on the left side where you need to document, all right, the upper and lower temporal as well as the upper and lower nasal. All right, this four quadrant is enough for you all. All right, it's a very basic and doesn't take too long. And with this, you can actually predict or somewhat guessing where the lesion is or stroke involving which part of the brain. Okay. As for Opthal, our assessment is a little bit different, but I'm not going to cover it today. Okay, so this is the visual pathway and visual field defect pattern. I'm not going to cover it now, but I hope you all still remember. Alright. So, this is the last slide of my presentation. The take-home message from this basic eye examinations lecture is systematic eye examinations. Basically, they are fast, practical, and clinically valuable. Please do it. Alright. And visual acuity must be checked in every patient with eye or visual symptoms. Eye symptoms means such as redness, okay, or tearing, whereby visual symptoms can be reduced vision, diplopia, floaters, and so on. All right, because visual acuity is the vital sign of the eye. So by assessing pupils, EOM, and visual field, you are actually detecting some neurological causes of the visual disturbance as well. And as you know, early recognitions of the red flags may save some sight as well as will save lives, because you know, if it involves neurological, we need to do urgent imaging such as MRI or CT scans, and then we need to refer urgently whether to neuromedical or to neurosurgical. Okay, and lastly, refer appropriately. Okay, we accept all cases related to the eye or visual disturbances. Okay, with that, thank you.
Thank you very much, Dr. Shahidatul, for that clear and comprehensive session. Next, we are honored to have Dr. Aiman Madya, who will be speaking about diabetic retinopathy. Dr. Aiman is our lecturer and general ophthalmologist from USM. Dr. Aiman graduated with MD from USM in 2012 and recently completed her Master of Medicine in Ophthalmology, also from USM in 2024. So, Dr. Aiman, kindly proceed.
Assalamualaikum and warmest welcome to all participants today. Thank you, Dr. Rahimi, for kind introduction. I'm Dr. Aiman Madya from Ophthalmology Department, University Science Malaysia. So, diabetes remains one of the most prevalent non-communicable disease in Malaysia, and its ocular complication, which is diabetic retinopathy, is a leading cause of preventable visual impairment. Today, I'm very delighted to share with all of you insight of diabetic retinopathy with our dedicated primary care providers. So your role as first liner in treating our diabetic patient is very important in order to ensure early detection, facilitate timely referral, and providing patients education. Together with these efforts are essential in reducing the burden of visual impairment and blindness among our patients. Sorry, my slides is quite earlier. So our objective today, we will learn about prevalence of diabetic retinopathy in Malaysia and a little bit on pathogenesis of diabetic retinopathy. Next, we will learn about diabetic retinopathy screening and staging and referral to ophthalmology clinic and a brief on treatment for diabetic retinopathy. So we goes to prevalence of diabetic retinopathy in Malaysia. Diabetic retinopathy is a complication of diabetes that caused by damage of blood vessels in the retina due to prolonged diabetes, which leads to vision loss and visual impairment. Prevalence of diabetic retinopathy is closely linked to patient's duration of diabetes and their level of glycemic control. And risk of related visual loss or visual impairment in patient with diabetes is up to 25 times higher than patients which are not having diabetes. And visual loss is the most feared complication of diabetes because patient will lose their functional quality of life and function. And this leads to reduce in independence and productivity. And patients also will have limitation in managing their diabetes by difficulty in reading nutritional information, difficulty in administration of insulin or any OHA medication, and also to check their own glucose level. And there is also difficulty to take care their foods and also doing exercise. Okay, there is a risk factor for diabetic retinopathy instead of the longer duration and high glycemic factor, which is patient who had pre-existing other comorbids of non-communicable disease such as hypertension, chronic kidney disease, CVA, history of ischemic heart disease, and patient having hyperlipidemia and anemia. Patient who are living sedentary lifestyle, smoking, and also diabetic patient in pregnancy is also affected more is more higher risk to develop diabetic retinopathy. But it is good to know that patients who are having good control of diabetes mellitus will delay the progression of diabetic retinopathy, and with good control of other comorbidities will reduce the severity of diabetic retinopathy. And for medical officer who is in charge in MCH, you have to know that patients, pregnant lady will have progression in diabetic retinopathy. Those healthy lifestyle is highly recommended in diabetic patient. Okay. At diagnosis, less than 5% patients with diabetes will have retinopathy, but after 10 years, the prevalence will increase up to 40 to 50%, and within 20 years, about 60% patients will have some degree of retinopathy. So diabetic retinopathy is a well-known leading cause of blindness among developed countries, and in our country, Malaysia, the prevalence of diabetic retinopathy from diabetic eye registry on 2007 is about 36.8%. In National Eye Survey 2014, out of all causative of blindness in our country, 10% is due to diabetic retinopathy. And on 2023, they did a survey in for the National Eye Survey. This prevalence is slightly reduced to 9.1%, but this might be due to a national policy of good control in diabetes. In order to have a good visual outcome, patients must have clear media from the anterior segment of from cornea until retina layer. So this is macula. Macula is an important structure that easily affected, that will be affected once there is distortion of the structure, and it is important for our central vision. Okay, next we go a little bit on pathogenesis, just nice to know things. This is microscopy photo of the retina layer. So where is the site of affected? At the capillary layer. Okay, what happened? There is two suggested pathogenesis, which is occlusion and leakage. For the occlusion, there is when diabetic patient, we know that patient going to have vasculopathy. There is some changes in basement membrane thickening, endothelial cell damage, red blood cell changes, and increase in platelet stickiness. This leads to occlusion of the capillaries, and loss of parasites will cause leakage to the surrounding structure. Okay, so this is general photo on diabetic retinopathy. We can see microaneurysm here, retinal hemorrhage, heart exudate, cotton wool spots, presence of abnormal new vessels, and also venous bleeding. Okay, next, what's our role as primary care? Patient, of course, they will present it to all of you before they come to us, ophthalmology team. So some of them at initial phase, yeah, they might be asymptomatic, and later on may have reduced or fluctuating vision due to lens or macular edema, and they might have floaters later on. That patient may describe as black spots or web-like spots in the visual field. This might be due to presence of vitreous hemorrhage, or later on, they can have visual field defect when there is tractional detachment, and patients who have macular edema might have central scotoma and distortion of vision that we call metamorphosia. Okay, so diabetic retinopathy screening, why and how? This is important to reduce visual morbidity. As we know, primary prevention is by screening to reduce visual morbidity and facilitate in early diagnosis and early treatment for sight-threatening retinopathy. How? We imply cost-effective method to cater large number of population at risk by doing screening to diabetic patient at our center. Okay, method of screening, we use baseline visual acuity is vital signs for ocular, at least using Snellen or equivalent chart. And yes, we have fundus photography in most health clinic. This can be taken by medical assistant or nurses, and later on grading by optometrists or family medicine specialists, and also trained graders. This is stages of DR. Why we need to have stages of DR? This is to improve communication between ophthalmologists and primary healthcare providers in managing patients with diabetic. So this international clinical disease severity scale was developed for diabetic retinopathy and also diabetic macular edema. In patient with mild NPDR, just only presence of microaneurysms that later on developed to moderate NPDR. There is more than microaneurysm, but less severe than NPDR. For NPDR, we use 4-to-1 rule, which is patient had more than 20 intraretinal hemorrhage, dot and blot hemorrhage in each 4 quadrants. And there is presence of venous bleeding in 2 or more quadrants, and in presence of intraretinal microvascular abnormality in 1 or more quadrant, but there is no signs of proliferative retinopathy. Then this condition, severe NPDR, about 50 to 75% will progress to proliferative diabetic retinopathy. This is example of proliferative diabetic retinopathy photos when patient presented with neovascularization and bleeding, either in vitreous or preretinal or even hyphema. Okay, so this is new vessel at this. It's very prominent, right? So this unstable new vessel is easily ruptured and may cause bleeding. So this is at the posterior segment. Patient might have vitreous hemorrhage or preretinal hemorrhage. This is new vessel as well. This is preretinal hemorrhage at the temporal region. Also preretinal hemorrhage, and there might be inferior VH due to the vessels is less visualized compared to superior temporal arcade. And this is complication of PDR, which is presence of new vessels in the iris. Patient may present it to you with sudden onset of eye pain, and also patient might have hyphema. Okay. And the advanced stage of diabetic eye disease, we call ADED. Any formation of fibrovascular tissue proliferation, tractional retinal detachment, dragging of retinal distortion, and also patient may have rhegmatogenous retinal detachment. Okay, next, diabetic maculopathy. Diabetic maculopathy can occur at any stage of diabetes, retinopathy. So it is characterized by accumulation of fluid within central portion of retina due to failure of blood retina barrier. When there is extensive leakage, it can cause diffuse edema. And when it is just a group microaneurysm leakage, it can cause focal or localized edema. And the heart exudate itself at the macular area can cause blurring and distortion of central vision. Okay, we have staging as well: absent, mild, moderate, and severe. If there is absent, means there is no retinal thickening or heart exudate at the posterior pole. This is posterior pole we call. Okay, and then mild, at the macula. There's presence of retina thickening or hard exudates in macula, but distance from the fovea over here, right? Okay, and at moderate, it is approaching the fovea, and for the severe one, yes, it is involving the fovea. Okay, next. When we need to screen patient at first diabetic retinopathy screening. When patient presented to you, we divide for adult, pregnancy, and children. For adult with type 1 diabetes mellitus, first screening is up to 3 years after diagnosis. And patients with type 2 diabetes mellitus, either adult or children, must be screened at time of diagnosis itself. Okay. And pregnancy lady with pre-existing DM, yes, we need to have a good planned pregnancy. So must screen for diabetic retinopathy as it may progress further during pregnancy. And patient with GDM, which is diagnosed at first trimester, must be screened at time of diagnosis. And children, diabetic, in children with diabetic, for type 1 diabetic, with 5 years of diabetic duration, we first screen at least at 9 years old, and for 2 years of DM duration, at least at age of 11 years old. This is algorithm for primary care in screening diabetic retinopathy, from viewing the fundus photo and grading, and if needed, refer to ophthalmology clinic. Okay, this is table for follow-up and referral. If patient had no diabetic retinopathy, we can follow up to 1 to 2 years. And then do mild, if patient with mild NPDR without maculopathy, up to 12 months, moderate NPDR without maculopathy, up to 6 months. Patients with maculopathy at any stage of NPDR must be referred to ophthalmology. And patient with PDR and ADED must be referred urgently to ophthalmologist for timely intervention. Okay, this is indication for ophthalmology referral. Emergency, which is same day referral when the patient presented to you with sudden severe visual loss, or there is any signs and symptoms of retinal detachment. And we can give appointment within 1 week if there is presence of new vessel, periretinal hemorrhage, vitreous hemorrhage, reversus iridosis, which is PDR. And then appointment within 4 weeks when patient have unexplained drop in visual acuity, any form of maculopathy, severe NPDR, and worsening retinopathy. Okay, next, ophthalmology referral. So what we do? Ophthalmology assessment, we will use slit lamp, direct fundoscope, and also indirect ophthalmoscope. This assessment, we will assess patient from anterior segment until posterior segment and proceed with investigation if needed. So we look for anterior segment, we look for presence of cataract, presence of new vessels at over the iris, and check the intraocular pressure if patient have new vessel in iris, as patient might have high intraocular pressure. And then we dilate to see the posterior segment. We stage as well, following the grading just now. Okay. Next. Nice to know investigation that we do at our clinic so that you can counsel patient for to compliance with ophthalmology referral. Okay. In diabetic maculopathy patient, we will do optical coherence tomography to diagnose diabetic macular edema and to identify subtypes of DME, and to look for any presence of macular traction. This can localize edema at specific layer of the retina. Okay, and if needed, we will do fundus fluorescent angiography in order to monitor failure or inadequate response to the treatment and to assess central and peripheral retina. Okay, my final part of presentation is about treatment. Generally, when we talk about diabetic retinopathy, we know one words, which is laser. Okay, how laser works. Laser will cause photocoagulation of the retina that further reduce metabolic and oxygen demand and cause regression of new vessels. Okay, in severe NPDR, we do scattered laser, and for PDR, we do full pan-retina photocoagulation. This session might be completed within 3 to 4 sessions. Okay, so this photo shows very prominent new vessel over the temporal arcade that regress after laser treatment, and you can see laser mark over here and regression of new vessels. And this is when there is new vessels at the temporal regions and also hard exudate. Then there is prominent laser mark. And this is when we do focal laser that involving the center, involving the non-center involving of diabetic macular edema. There is hard exudate initially over the macular region that markedly reduced after laser treatment. Okay, for intravitreal antivascular endothelial growth factor, or easily known as VEGF, it is a primary treatment for center involving diabetic macular edema. Recommended loading dose is 3 injections with 1 month apart and can go up to 5 injections. And then potential adverse effect include transient increase in intraocular pressure, and patient might have injection-related infectious endophthalmitis, which we prevented with antibiotics post-procedure. And there is a potential risk of patient developing thrombotic events following intravitreal use of anti-VEGF. So this is how we do intravitreal treatment for anti-VEGF under steroid procedure, of course. And this is our aim, to administer medication to the posterior segment direct to the macular region. And post-treatment, here we monitor and we can show this photo to patient early when it is indicated, and post-treatment marked reduce in macular edema. Okay, and steroid implant, when patient at risk of cardiovascular disease, we do steroid implant as first line. And in advanced stage of diabetic retinopathy, which is ADED, we need to refer to consultant vitreoretinal to proceed with pars plana vitrectomy, membrane peeling, and also endolaser. The indication is to clear the vitreous hemorrhage for better vision and to release fibrous traction and flat the retina. Okay. So this is a brief procedure. And last one, treatment of pregnant lady with diabetic macular edema. Yes, they are at higher risk of development and progression of retinopathy. Treatment include laser and intravitreal corticosteroid. Fetal safety is a concern, so we will avoid anti-VEGF. If patient had severe diabetic macular edema, we may consider intravitreal dexamethasone implantation. In summary, a strong understanding of diabetic retinopathy will empower primary care practitioners to make a real difference in managing diabetic patients. So by optimizing diabetic control, recognizing early stages of retinopathy, and ensure timely referral to ophthalmology clinics, we can significantly reduce risk of visual impairment and blindness in diabetic patients. Okay, these efforts not only preserve patient sight, but also enhance patients' quality of life. And thank you for your continuous commitment in improving the patient's care and outcomes in patients living with diabetes. With that, I end my lecture. Thank you. Back to Chairperson, Dr. Rahimi.
Thank you, Dr. Aiman, for that informative presentation. And I'm sorry to inform that we have a change of schedule. So we are going to proceed to our next lecture by Dr. Ainashra, presenting on red eye. Red eye, is it just conjunctivitis? This is one of the most common ocular complaint in primary care, and she will help us differentiate benign from more serious causes. So Dr. Ain, please proceed.
Assalamualaikum and a very warm welcome to everyone. Thank you very much for joining us for today. So I'm Dr. Aina Shram Askari, General Ophthalmologist in Hospital Pakar University Science Malaysia. So my topic is red eye. Is it just conjunctivitis? I hope everyone can hear me. All right, so what are our learning objectives today? Okay, first, our aim is we want to differentiate the common causes of red eye and be able to perform an efficient red eye assessment in the primary care setting. And most importantly, identify the red flags that indicate urgent ophthalmology referral. Okay, so what actually causes red eye? So it's actually because of conjunctival hyperemia, which is the dilation and engorgement of conjunctival vessels. Okay, as seen in these photos here. So it is a vascular response triggered by various causes. So it can be range from infection, inflammation, irritation, trauma, or a sudden increase in intraocular pressure. And in these causes ranges from benign and self-limiting to, most importantly, sight-threatening emergencies. So it's important for us to be able to differentiate the causes of red eye. Okay, so what actually differentiates one red eye from another? So it's important to know the difference of symptoms and signs, which includes the history taking. Okay, so it's good to have a detailed history about the patient condition, and then pain. Is it severe? How did it start? Is it only mild? Is it associated with anything else? Can the vision, how bad is the vision impairment? Is it just mild, or is it like a sudden? Is it associated with pain? Okay, any discharge if present, the pupil size, any difference from the right and left? Is it sudden change in the pupil size? And a fluorescein test. Okay. Okay, so here are photos of various red eyes, and then if we can see clearly, there are features that are different from one to another. Okay, so if you can see from all these photos here, all are red eyes, but then there are details that differentiates them from one another, which I will go in my next slides. Okay, so first, conjunctivitis. Okay, I'm sure conjunctivitis is one of the most common presentation in a primary care setting. Okay, so conjunctivitis can be of bacterial, viral, or allergic in origin. It can range from mild to severe. And then usually in viral conjunctivitis, the most common cause is adenovirus, and it can also occur after any viral infection. Okay, and viral conjunctivitis is generally very what do you call it? It can transfer from each person very fast. Okay, and then we have bacterial conjunctivitis, and then also allergy. Okay, so what's important in the history, signs and symptoms is to know the onset and duration of symptoms. Okay, any impairment of vision, usually in conjunctivitis, it's just mild, okay, impairment of vision, and the presence of itch, which is more pathognomonic for allergy. So it's also important in the history to ask if this patient has any allergic history. Okay, any discharge, typically in viral conjunctivitis, the discharge is more watery, more clearer as compared to in bacterial conjunctivitis, which tends to be more thick, more purulent, more yellowish. Okay, matted lashes, which if you can see in this top right photo, you can see the lashes are like stuck together. Okay, so this is what we call the matted lashes. Okay, any exposure with a person who had conjunctivitis. Okay, and then once again, any presence of allergies. So, okay, this is actually a slit lamp photo, showing this bumpy, the bumpiness, okay, in the texture of the purpura conjunctiva. So this is what we call follicles, which is frequently seen in allergic conjunctivitis. Okay. Okay, so this is a membrane. Okay, it can either be a true membrane or pseudomembrane. So what is it? It is a conjunctival inflammation with the formation of fibrinous sheets and inflammatory debris on the epithelial surface of the conjunctiva. So patients with pseudomembranous conjunctivitis, it is important for the ophthalmology team to be able to clear it up. So if you see cases of conjunctivitis which does not, takes a long time to resolve, and then it looks like very injected, and then you are able to notice a layer over here, it is best to get a referral to ophthalmology, so we are able to properly manage with this information. Okay, this membrane. All right, and also just to show you a variant in allergic conjunctivitis, which is vernal keratoconjunctivitis. So here you can see there's a papillae, the bumpiness here. Typically, we call it a cobblestone papillae, and you can see it is very large in size as compared to the previous follicles. Okay, so this is also typical in cases of vernal keratoconjunctivitis, and then in this kind of case, it requires a more precise, targeted treatment, which is important for referral to ophthalmology department. Okay. All right, okay, coming to corneal ulcer, one of the ocular emergencies. So what is corneal ulcer? It is infective keratitis. It can be of bacterial, viral, fungal, parasitic, or even sterile in origin. Okay, so what it is an epithelial defect with an inflammatory stromal infiltrate. Okay, so when I mention epithelial defect, okay, if you can see this photo, this is actually a fluorescein stained cornea. Okay, the green part of this, okay, which we have instilled a fluorescent strip in here and then shine it with the blue light, and you can see the area that lights up green here is actually the part where there is an epithelial defect. Okay, so if you can see this photo, the most left side photo and the one next to it is actually from the same eye. Okay, so this is without stain. So you can see there's an opacity and haziness centrally. So this is actually it's a contact lens related corneal ulcer. And then when we stain it with fluorescein, you are able to see, oh, there's actually a huge epithelial defect here. Okay, similarly, these two photos are the same, but what's different in this photo is that this patient also has a hypopyonicite. So it signifies much inflammation going on here. Okay, much severe inflammation going on. Okay, so this is the central infiltrate, and then when we stain it with fluorescein, you are able to pick up that, oh, there is actually an epithelial defect here. Okay, so these kind of cases, it requires urgent referral to ophthalmology team. Okay, so what do you want to ask for patients with corneal ulcer? Okay, first is the onset and duration of symptoms, the impairment of vision, have to check the visual acuity, any pain, discharge, history of contact lens wear. It's good to know the hygiene wise of how they care with the contact lens. Okay, any comorbidities, history of trauma, history of like insect entering into the eye, how they deal with it after that. Okay, and any presence of allergies, because as I showed in the previous slide, okay, these kind of papillae, they can also erode the corneal epithelium, which ultimately leads to a sterile corneal ulcer. Okay, it's not infective related. Right. Okay, so coming to preseptal and orbital cellitis. So what are the difference between preseptal and orbital cellulitis? Is that periorbital cellulitis or preseptal cellulitis, it's the inflammation that affects the skin and soft tissue beyond in front of the septum. So this is the orbital septum. Okay, so when only these parts are infected, so that is preseptal cellulitis. And orbital cellulitis, it affects deeper tissues beyond the orbital septum. So it is much more site-threatening, okay, it's more dangerous as compared to preseptal cellulitis. So it's important to be able to recognize what differentiates preseptal and orbital cellulitis. So important things to ask is there any history of insect bite, which is common in our community, especially in Kota Baru, in Kelantan, is tick bite, okay, to the lids, and then any injury near the eye area, any recent infection or inflammation of the neighboring area, such as sinusitis, any dental caries, necrocystitis, any systemic infection. Okay, so important thing to note is that the degree of vision impairment or presence of any. Okay, receptor cellulitis can have no vision impairment as well, or even mild. Okay, the ocular motility, because in orbital cellulitis, the extraocular muscles, okay, and the neighboring the cranial nerves can be affected, which limits the ocular motility. Proptosis, which is very significant for orbital cellulitis. How about the optic nerve function, which is important in assessing orbital cellulitis, and then general well-being. Okay, so it's important to remember that orbital cellulitis is an ocular emergency. Okay. All right, so red flags is that severe vision impairment, pain on eye movement, diplopia, limited ocular motility, okay, proptosis, RPD, post-RPD, and then if patient is systematically ill. So if you see these three photos, okay, so these two photos are actually, you can see like it's very swollen, it's very red, but these are actually preseptal cellulitis, post-tick bite infection. So these patients were treated with oral antibiotic and then subsequently recover. But generally in pediatric cases, we do admit them and start them on intravenous antibiotics. Okay, and then for these kind of patients, but if you see the other photo, you can see from here that this child does look generally like unwell. Okay, so it's important to note to check the ocular motility, okay, the vision. It's just highly likely to be an orbital cellulitis, okay, which needs a more aggressive treatment. All right. Okay, carotid cavernous fistula, CCF. Okay, what is it? It is the result of an abnormal vascular connection between the internal carotid artery, okay, or external carotid artery and the venous channels of the cavernous sinus. So there are various classifications. There's actually type A to D, if I'm not mistaken. Okay, so direct CCF and also indirect CCF. Okay, so direct CCF, it often presents with a classic triad of pulsatile exophthalmos, orbital Bruin chemosis. Okay, it can have, and then both CCF, direct or indirect, can have double vision, diplopia, ocular redness, orbital or orbital pain, swelling, swishing or buzzing sounds, headache, or vision loss. And then important to remember in primary care setting is that indirect CCF, the most common presentation of it is conjunctival injection, which can masquerade as conjunctivitis. Okay, so just to show you, okay, both the direct and indirect CCFs, they can have proptosis, eyelid edema, ptosis, conjunctival arterialization, which I'll specify further on next slide. Okay, elevated intraocular pressure, positive exophthalmos, check the pupillary abnormalities. Okay, just to check the nerve function, cranial nerve function, any ocular misalignment, papillary edema, if you have access to the fundus photos. Okay, dilated retinal veins, ischemic optic neuropathy, central retinal vein occlusion, or choroidal detachment. Okay, just to show you that here is a chemosis and then it has collapsed out. Okay, and then the eye is very, conjunctiva is very injected. Okay, and then there is a significant degree of proptosis in this eye. And then for this other patient, I just want to show you the primary gaze of this patient. Okay, so when he looks front, okay, you can see that there is a prolapsed chemosis here. Okay, but he has a limitation in both right and left gaze. Okay, which signifies an involvement. There's an impairment in the extraocular muscle. All right. So when I mentioned about conjunctival hyperemia as a result of arterialization of conjunctival and episcleral veins, okay, this is what we call the corkscrew vessels. So you can see the typical the morphology of it, okay, you can see lateralization is, it is much more dilated and then tortuous, and then it converges here at the limbus. Okay, so this is typical of a carotid cavernous fistula. So it's the arterialization of conjunctival and episcleral veins. Okay, so what are the red flags suggestive of CCF? Okay, unilateral red eye, positive proptosis, the arterialized conjunctival vessels, cranial nerve palsy, especially sixth nerve, pulsatile tinnitus, chemosis disproportionate to just a simple conjunctivitis, any history of visual head trauma, which is more significant in direct CCF, okay, any sudden onset double vision. Okay. So, acute anterior uveitis. So, uveitis is a range of disease. It's inflammation of uvea. It can be either anterior, intermediate, or posterior, or even panuveitis. But for this topic, I'll just focus on anterior uveitis. Okay. So, what we see is a red eye. And then if you can see clearly, there's something wrong with the pupil here. Okay. It's not round. Okay, it's not a nice circle. So you can see there's a bit of like this a weird shape here. Okay, so this is actually signifies there's a posterior synechiae, a part of inflammation going on at the iris margin. Okay, so AAU, the anterior portion of the uvea, iris, and anterior body, primarily affected by the inflammation. It can occur as an isolated problem without any systemic association or in the context of a multi-system inflammatory disease, and it can also be recurrent. So what do these patients have? They can have reduced vision, eye redness, pain, and photophobia. And as I mentioned, try to look at pupil size, compare from the right and the left eye. But anterior uveitis can also be involve bilaterally. Okay, just to show you, this is our slit lamp photo, which we can see a more focused view of the cornea. So you can see there's like dots, pigmented dots over here. So which is actually keratic precipitates, okay, which is an inflammatory process in uveitis. Right, endophthalmitis. Okay, this is a serious sight-threatening intraocular inflammatory disorder resulting from infection of the vitreous cavity. It can be exogenous or endogenous in origin. Okay, so for exogenous origin, it can occur after intraocular surgery, especially cataract surgery, intravitreal injections, penetrating trauma. And for endogenous origin, it can occur from endogenous seeding from systemic infection, most commonly from Klebsiella, okay, pneumonia. Okay, so what are the symptoms? Severe eye pain, markedly reduced vision, red eye, photophobia, floaters of flashing lights, lid swelling. So in these two photos, which I show you here, okay, so these are two different images, okay. So this patient, okay, so he has, you can see this photo, like the cornea is very hazy. You can barely able to see the pupil structure, okay, even the iris is not very visible, and then you can see an hypopyon level in here. So this signifies an alert so you already have to have endophthalmitis as one of your differential diagnosis at this point of time. Okay, so in this kind of patient, you're not able to see the fundus, okay, because of the haziness of the cornea. And generally, when patient already has this kind of hazy cornea, the intraocular pressure is typically high, and then they'll be in so much pain, vision severely reduced, right? Okay, so if any of these occur post-cataract surgery, post-injection, or post-trauma, remember to reverse that. So does the patient have any rapid drop in vision, severe ocular pain, hypopyon, any red eye with photophobia post-procedure, hazy cornea, absent, no fundal view, floaters with pain and redness, any history of penetrating injury, and the patient is systemically unwell with a new eye pain, which is likely endogenous, especially if you are in like a district hospital and then you have a patient with a systemic infection, okay, and then suddenly has a red eye, reduced vision, and the patient is already systemically unwell, there is a high likelihood that the diagnosis will be endogenous endophthalmitis. And then endophthalmitis is a time critical emergency. We don't want to delay management, okay, so it's important to refer staff. Okay, I think this might be my last disease here. Okay, acute angle closure. What it is it is angle closure of the eye Okay, so it is diagnosed when the intraocular pressure is more than 21 millimeters mercury with occludable angle. Okay, this is more significant for ophthalmology for the occludable angle part. Okay, so what's important is you have to know the symptoms. Okay, so when we say it's AAC, the symptoms must be any two of the following symptoms: ocular and periocular pain, nausea and or vomiting, history of blurring vision and halos, and any three of the following signs. So is there any conjunctival injection, corneal epithelial edema, mid-dilated unreactive pupil, and shallow anterior chamber? All right. So this photo, you can see this is a slit image. Okay. The blackish part here is signifies the anterior chamber depth. And you can see it's quite shallow. Okay, so what you can do in your setting is that a torchlight test. So you shine it temporarily. Then when you shine the torchlight to the eye, I'm sorry, I don't have the photo of it, but you can search it online. Okay, so you shine a torch from the temporal part, and then in a deep anterior chamber, the whole iris would be able to be illuminated. Okay, but if in a shallow anterior chamber, there will be a shadow, like a crescent shadow. Okay, which signifies. Sorry, I'm always struggling with that word, which signifies shallow angle. Okay, shallow anterior chamber. So you can see this photo, red eye, shallow anterior chamber, mid-dilated pupil, okay? And then patient would already at this point have headache, nausea, vomiting, and reduced vision. Okay, so AAC, sudden obstruction of aqueous outflow leading to rapid intraocular pressure rise, leading to optic nerve damage. You get this photo here. And then without urgent treatment, permanent vision loss can occur. So any red, painful eye with decreased vision, hazy cornea, and a fixed mid-dilated pupil will be acute angle closure until proven otherwise. So refer immediately, and AAC is also a time-critical emergency. Okay, so important slide, okay, at least get a snapshot of this. Okay, red flags, any sudden vision impairment or vision loss, red eye plus pain, red eye plus suspicion of a serious pathology, infection, suspected orbital cellitis, severe preceptor cellitis in a child, or progression despite on antibiotics, any restricted eye movement, proptosis, pupil, anisocoria, which is the difference in the size between both pupils. Okay, trauma, I won't go detail in this because Prof. Azani will talk further on ocular trauma. All right. So, but the red flags in trauma is generally penetrating, suspected open globe injury, chemical injury, blood trauma with reduced vision, large subconjunctival hemorrhage, hyphema, or double vision. Okay, so recognize fast, also important slide. Take a snapshot of this. Okay, AAC, acute enclosure, severe pain, reduced vision, hazy cornea, mid-dilated fixed pupil, nausea, vomiting. Okay, think of AAC, endophthalmitis, any recent eye surgery infection, severe pain, recent eye surgery or injection. Severe pain, rapid reduced vision, hypopyon, hazy cornea, think of endophthalmitis. Okay, so orbital cellitis, any painful extraocular muscle movements, there's fever, there's proptosis, there's vision changes. Okay, think of it. And then for corneal ulcer, corneal stain or any infiltrate, reduced vision, pain and photophobia. Okay, it might be corneal ulcer. So that's all from me. Thank you for listening.
Okay, thank you, Dr. Ain, for the clear and practical explanation. We now move to our next session, will be by Prof. Azhani, who will cover approach to ocular trauma. Eye trauma can present in many forms, and timely recognition can make a big difference in patient outcome. So, Prof. Azhani, please welcome.
Okay, thank you, Dr. Rahimi. Yeah, Assalamualaikum and good morning once again. Okay, so I'm going to continue our webinar today talking about the approach to ocular trauma. So yeah, I'm going to have to share the practical sharing for the primary care. Okay, so basically this topic is quite big. So what I'm trying to do today, I try to simplify and try to share the cases that really related to the primary care. Okay, for the introductions, in terms of classifications of the ocular trauma, there is a system that called as Birmingham eye trauma terminology, in which that in this classification, it's divide the ocular trauma into two, the closed globe trauma and the open globe. And under the closed globe, there is contusion, lamellar laceration, and under open globe, there is a few, which are rupture, laceration, penetrating, perforation, and IOFB. But for today's, what I'm going to do is just using simple classifications, which is easy to remember, which is the trauma classified into blunt injury, penetrating injury, and also the chemical injury. Okay, a bit on the prevalence. This is from the quite recent data from the publication in 2024 about the ocular trauma at Hospital Kuala Lumpur. Okay, we can see that the main area that have been having this ocular trauma is the workplace, domestic accident, and also the motor vehicle accidents. And most of the cases, 56.4% is actually under an open type of injury. And if we go to try to see what's the accident objects, can see that the things that causing the ocular injury is either metal or nail. This is the common or the main causing the ocular injury. But of course, all this is the ocular trauma that actually referred to Hospital Kuala Lumpur. Okay, maybe the mild one is not there. Okay, so the common cases of ocular trauma seen in primary care can be just simply eye accidentally hit by something, okay, either nail, wire, pencil, branch or tree, okay, shuttlecock, okay, or eye accidentally splashed by something, okay, this is more of the chemical injury, or when the eye involved in the motor vehicle accidents, okay, or just that the patient's having a fall. So general approach when we see the cases with the ocular trauma, first is the history, okay? If we have, to those cases, especially that involved in the motor vehicle accident, we have to rule out the life-threatening condition first, okay? So that one, we have to, and after that, but we have for the vision. Okay, so we need to know the premorbid history. For example, patients is diabetes or not. Is there any ocular history before, okay, in which that either the eye is not so good seeing eye or is it a normal eye? And we want to know what's the causes for the injury, okay, and what are the current symptoms that patient have. Either the vision is still good, is the patient having the ocular pain or not? And for the examinations, as mentioned by Dr. Shida in the beginning of the webinar, right? So the main thing is that the visual acuity of the patient, we need to test for the RAPD, look at the external ocular, try to look at the pupil, the red flags, the fundus, and also to check for the extraocular muscle movement. And sometimes we need to check for the visual field as well. Now I go to each type of the injury. The first one is the blunt injury. Okay, the example of the blunt injury, the common from the sports, like being hit by the shuttlecock, okay, or hit by the tennis ball, or in punch, okay, by the hands, and sometimes games, toys, for example, the gun bullets, okay. So in this blunt injury, they can have like a periorbital hematoma, cornea abrasion. They can present as hyphema, traumatic mydriasis, dislocated lens, angle recession, vitreous hemorrhage, retinal detachment, TON sometimes, and sometimes floor fracture. So I guess the one that commonly seen is like cornea abrasion and subconjunctival hemorrhage. Okay, so you can see here, right, the photo with the fluorescent, can see that the staining of the positive staining of the fluorescence. Okay, that one is the cornea abrasion, and the second photo downwards here is the conjunctival, subconjunctival hemorrhage. So in cornea abrasion, usually the patient will tell that patient having eye pain and watery, and most of the patient can open up their eyes, okay? And however, in terms of visual acuity, usually just minimally affected. And when you stain, there will be a staining positive. And the treatment for this patient is ointment antibiotic and just pat the eye for 24 hours. For the subconjunctival hemorrhage, patient usually come with a symptom of mild discomfort. Usually the visual acuity is good, okay, and we need to confirm that there is no other injury. And the treatment is quite simple, just that we need to give the topical antibiotic. The other common presentation from the blunt trauma is the hyphema. Okay, hyphema in our Asian eye, right? In our Asian eye, because we have the black iris and the or dark chocolate iris, so it's not easy for us to really appreciate the hyphema, especially the hyphema is just minimal or just the hairlines, okay? So, but from the history, if the patient tell us that patient having the eye hit by the ball or shuttlecock, for example, or tennis ball, right? So we know this is the blunt trauma, okay? And patient having the eye pain, most of the time patient will complain that the eye is, the visual acuity is reduced than before, okay? So we have to, it should trigger our mind that most likely patient is having hyphema. And hyphema, there is also what we call as microscopic hyphema, means that from our naked eye, we can't see any hyphema, but actually if we examine patient under slit lamp, there is a cells of blood, okay? So that's mean patients having hyphema, just that it's not that obvious. So when you examine the patient having the low visual acuity, and sometimes the pupil also affected. For example, most in blunt trauma, they can have this, what we call as traumatic mydriasis, and the presence of blood in the anterior chamber. So in the case of hyphema, or even if you know that there is something hard hit the eye, even though you can't see the hyphema, right? We need to refer to the ophthalmologist. Why? Because we need to examine under a slit lamp, and if even the microscopic hyphema, we need to monitor that hyphema, and we need to see either there is a secondary bleed later on, and also in terms of intraocular pressure. And usually in what we do is that a patient need to be rest in bed completely, okay, with prop up 45 degrees, so that the blood will through gravity will coming down and give a topical steroid. Okay, the next one is about the corneal foreign body. I put it under the blunt trauma, right? Because yeah, because this is quite common in the primary care, that patient, especially the workers, okay, that works in the welding, a welder, right? So yeah, just like this patient, they have the glasses but not wearing it properly, put it on the head instead of wearing it. So this is quite common for them to have this foreign body from a metal. Okay, so when patient come with the history of welding and something goes into the eye and patient having a foreign body sensation, yeah, that's mean we need to look, is there any foreign body on the cornea? Sometimes it's not on the cornea, then we need to invert the eyelid, okay? And if we give the fluorescent, sometimes there is also abrasion or small, what we call as superficial pantechny, the SPK, right? And sometimes it's due to the heat, right? Because they're not using the proper protection to the eye, so they can have it. So for this cornea foreign body, usually they will complain of something inside the eye watery, pain, and also the redness. And sometimes just that using the torchlight examination, you can see the foreign body on the cornea, okay? So at primary care, what you can do, we can try to irrigate the eye with the normal saline. If able to remove, then need to give the antibiotic and ask patient to come back, because sometimes when the foreign body dislodge, okay, sometimes the secondary infection can come in. Okay, so that's why need to have ask patient to come back so that you can review the patient. However, if unable to remove, please, we need to refer this case to the ophthalmologist. So in our clinic, we're going to remove the foreign body under a slit lamp, and we give the antibiotic after that. Okay, there is 2 photos here, right? In which that we can see there is 2 black spots on the cornea. Can you spot the difference between 2 photos? Okay. Is it the foreign body or something else? Okay, so actually this one on the right side is the upper metal rust there. Okay, iron dust over there. But then for the left side, it is actually a perforation of the cornea where there is a iris that plug on that cornea. So it looks like the same, right? But what's the clue? The clue is that you try to look at the pupil there, because if the iris prolapse, protrude to the drain, you can see that the iris become distorted. Okay, so what I'm trying to show is that don't just simply pull or try to pick up the things, but not all black thing on the cornea is a foreign body. Okay, so other things that can happen in the blunt trauma is the orbital blowout fracture. Okay, this one usually a big thing that hit the eye. Okay, so patient may complain of a few things. For example, pain, redness, and then patient can have diplopia sometimes, right? And then blurring of vision. Okay, so the first photo here can see that if we really look, actually the eye looks smaller. Actually, not the eye looks smaller, but then the eye is actually inophthalmos, okay? And then can see that the periocular ecchymosis and also the edema, okay? And if we ask patient to check for the extraocular movement, try to look up, right? Can see that it's not similar between 2 eyes, okay? And patient can say that there is a diplopia at the same time, okay? So yeah, this is the CT scan of this patient. You can see that actually the floor is not there already. So this is the example. Of course, this type of cases, if you see something hit the eye, yeah, you need to refer patients to us. Okay, the next one is the penetrating injury. Penetrating injury, right? The common causes is from the grass cutting activity that they do without the eye protection. Motor vehicle accidents, of course, glass windscreen injury, or any injury by the sharp object. For example, at school, like a pencil, mechanical pencils, right? And this penetrating injury can have many things. For example, it can end up with corneal laceration, conjunctival scleral laceration, traumatic cataract, iris injury, vitreous hemorrhage, retinal tear, retinal detachment, lid injury, or NLD injury. Okay, so this is important slide for you to take note, right? Whenever there is a penetrating injury, right? When cases of penetrating injury come to your clinic, right? One thing is that we need to ask patient to kneel by mouth, but because most of the time we need to bring patient to the OT urgently. Okay, and then the ETT, intraocular foreign body, possible in the case of grass cutting, for example, need urgent referral to ophthalmologist. So how we send patient to the ophthalmologist is that we need to use the eye shield. Okay, eye shield or just modified eye shield. Please do not pat the eye, because when there is a penetrating injury, it means that there is a continuation from inside and outside the eye, right? So if we pat the eye, we might put a pressure on the eye and causing more damage to the eye. Okay, do not try to manipulate the eye. Okay, try to examine, because most of the time in penetrating injury, it is very painful condition. Patient won't be cooperative, and do not instill any eye drop as well. Okay, so this is the example of the eye shield. Yeah, of course, this one is the commercial one. But if you don't have it in your premise, in your clinic, we can just do the DIY. Okay, in which that you can just use simple either the paper cup, right? Or even the saline bottle, you can just cut and put it like that. So why we want to do it like this? First is that protection to the eye, so that from the further dirty conditions. The other thing is that we're not pressing the eye. Okay. So how we want to know this is penetrating injury, especially at the cornea, is that by standing with the fluorescent. Okay, so for the fluorescent, here I'm having the video here. Okay, what we call is as fluorescent needle test. Okay, I try to. Okay. Okay, when we stain the eye, okay, usually the green color is there. When there is a penetrating injury at the cornea, cornea laceration, we can see that there is a dilution of the staining. Okay, let me repeat again. Okay, why it's happened like that is that because inside the eye, we have the aqueous, right? So this aqueous, when there is a full cornea laceration, full thickness cornea laceration, the aqueous will go out from the cornea, through the cornea. So it will dilute the staining. Okay, so this is the things that can happen usually during this penetrating injury during the grass cutter activity, grass cutting. Okay. From just without the staining, we can see that it looks like one line there. You can look at this photo A. There is like opacity, one line opacity. So from this one line opacity, if just abrasion, it can just come out with fluorescent staining like this at B. But if there is a full thickness laceration, you can see the siddle positives as in the video just now. And sometimes patient just presented to you, to us is with full hyphema like this. We can't see anything, just that this full hyphema. We have to bear in mind possibility also, there is also penetrating injury at the same time, just that we can't see. Okay, so we need to do further investigation. So that's why grass cut cases that having trauma from the grass cutting activity is like a must to refer to the ophthalmologist for further evaluation. So like this patient D, right, you can see that in the CT scan, there is a foreign body over there. Okay, the other example of what we receive here from the penetrating injury is like a fishing hook there. Yeah. Okay, if you see anything that hook or in the eye, please do not pull the object from the eye. Okay, yeah, you know, because sometimes in emergency, the patient's crying, especially the kids, right? They try to pull everything. So please hold it, right? Put the shield, okay? Try to this one because we can't just put because it will cause more damage to the eye. Okay, so same goes to the other things like the nail over here, the wire, okay, or the mechanical pencils. Okay. Okay, this one, yeah, this is the quite common scenario also. Either skidded bicycle, skidded motorcycle into the bush, right? And when they come up, oh, they feel some pain on the eye, in the eye, and then went to the clinic, and it seems like, oh, something on the cornea. Okay, before we do something to this one, please think first and please properly examine. Like both of this photo, it shows that it's not a foreign body, even, okay? It is the iris that prolapsed through the cornea laceration or limbal laceration. That's why we can see that the pupil is distorted, okay? Like a oval shape like that. Okay, so please don't pull again, put the eye shield and refer to the ophthalmology. Okay. Same goes to the more devastating condition like this one, the motor vehicle accidents, in which that if the eye is like this, you can see that the iris all come out, right? And some material also looks like lens material come out also, right? So this is most likely is a globe rupture. Don't do anything, just put the eye shield and transfer patient to the hospital, to the ophthalmologist to do the further management. Okay, the next one is the eyelids injury. I put it under penetrating injury because it's quite easy, right? So when you see eyelids injury, is it anyone can repair? Because it looks very small, right? Is the eyelids injury looks sometimes it's come very small, right? So is it anyone can repair? No. Okay, the answer is no. Okay, for the eyelid injury, either plastic surgery or ophthalmologist can repair. Okay, so that's mean all patients with the eyelid injury needs to refer to the hospital. So in the hospital, usually the emergency department doctors will see either want to refer to the plastic surgeon or refer to the ophthalmologist. So the key point is that for the ophthalmologist, we need to repair the eyelids injury that involve the margins and also eyelid injury that involve the canthal area. Canthal means that at the corner, okay? Either the medial corner or the lateral corner, medial canthus or lateral canthus, okay? Why the medial canters is important is that because we have this nasolacrimal drainage system. Okay, when there is a cut at this medial canter area, most likely the canaliculi, okay, is affected, is injured. And if it's not properly repaired, patient will have epiphora or watery of the eye, okay, for the rest of their life. Okay, so that's why these cases need to be referred to the ophthalmologist. I have one experience about regarding this very minimal small cut at the lower part of the canaliculi. A boy that playing the football and then suddenly fall at the edge of the fence. So it hit the wire of the fence. It's minimal bleeding. So went to the GP at that time. The bleeding already stopped and it looks like very small cut. So the GP just give ointment CMC and discharge. But the mother the next day come to the ophthalmologist because just want to have a check. Yeah, it's a cut. So the patient need to bring back to the OT for a proper repair of this canaliculi. Okay. The next one is the chemical injury. Okay. Chemical injury, right? The common cause of causes for acid and alkaline chemical injury. Okay. This chemical injury can be divided into acid or alkaline. Okay. Of course, sometimes we don't know, right? What type of agent that splashed to the eyes. Okay. So we need to know what is actually. So most of the time, if acid from the car batteries, from the bleach, okay, and vinegar, okay, and sometimes from the swimming pool, okay, the acid from the swimming pools, all this is the acid. And if from the alkaline, example is like plaster, cement, okay, cleaning agent, the fertilizers. So this is all the acids. Alkali burns is more dangerous compared to the acid burns, okay, because it penetrates very rapidly. Other things that also consider as chemical injury, such as the firecrackers, okay. Firecrackers is one of it. So if the child, especially the child, right, having the firecrackers injury, either what you need to do is that you need to do the irrigation first, right? Because it's also chemical injury. Other thing is that this snake, okay? So the venoms also, we consider it as a chemical injury in which that we need to do the irrigation, okay? So this is the example of the types of injury that can happen when the chemical agents splash to the eye. Okay, the corneal abrasions, the opacity, the cataract, the limbal ischemia, and if it's go further, it causes retinal detachment, retinal toxicity. So this is considered as ophthalmology emergency. Okay, so this is the only injury that you no need to take history for the patient. If patient said that something splashed to the eye, okay, just like battery from car battery that splashed to the eye or acid from the cleaning that splashed to the eye, what you need to do is that straight away, immediately need to irrigate the eye with copious irrigation. Just use saline or clean water for at least 20 to 30 minutes, okay? Ensure that the eyelids are fully open during the irrigation, okay? Do not delay the irrigation for any reasons. After irrigation, need to refer to the ophthalmology. And if your premise, you have the pH, the litmus paper, then check for the pH. Okay. If still acidic or alkaline, then continue the irrigation until it becomes neutral. Okay, so this is the example how you can do, how patients can do the eye irrigation at sites, right? Okay, need to open the eye. If both eye, just shake away like that. Or, okay, if only one eye that splash with the chemical agent, make sure that during the irrigation, okay, only that eye, I mean, the agent not goes to the other eye. If not, then from one eye, then become bilateral eye that involved with the chemical. Okay, so this is how we can do the eye irrigation at the premise, okay, in a clinic. So just put the saline, right, as usual, and use the infusion set, okay, and just ask patient to turn to the temporal part if only one eye, okay, just patient turn to the temporal part and irrigate from the inner canthus to the outer canthus. But let's say bilateral eye is involved, right? So just use two at irrigation at the same times, not one by one, okay? So we need to have two saline bottle at the same time running irrigate the eye. So that's all for today. The take-home message is that most ocular trauma cases need referral to ophthalmologists. High index of suspicious, especially cases that you're unable to examine, and chemical ocular injury is emergency. Copious irrigation is needed before anything else. So that's all for today. You can ask any questions. Okay. Yeah.
Okay. One an urgent referral to ophthalmology.
Organic? Yeah.
Bacterial, foreign body, need
Mm.
an urgent referral to ophthalmology.
Okay, yeah. There is one question. If organic material what foreign body?
Foreign body.
Yeah, yeah. So yes, need urgent referral to ophthalmologist. Yeah, you are right. Any other question? Tak ada.
Or
Okay, I can answer the question afterwards if is there any other. Okay, that's all. Thank you.
Yeah. Thank you, Prof. Thank you very much, Prof, for that excellent and insightful lecture. I'm sorry to inform that we need to combine our Kahoot session from 2 to only 1 session at the end of our course today. But no worry, we have a huge number of cash prize to be won, so stay tuned. So we now moving to our next lecture by Dr. Ang Kuan Sheng, who will be sharing a very important topic, do's and don'ts in treating eye disease. Dr. Ng is our medical lecturer and ophthalmologist in USM. Dr. Ng graduated MD from USM in 2013 and obtained his Master of Medicine in Ophthalmology, also from USM in 2022. So, Dr. Ng, please welcome.
Very good morning to all. I'm Dr. Ng Guang Sheng. I'm a lecturer and ophthalmologist from Department of Ophthalmology and Visual Science, University Science Malaysia. So the topic today I'm going to discuss with you all is the do's and don'ts in treating eye diseases. So it's actually pretty much a sum up and also re-emphasize on what you should do and don't do in correspondence to the previous speakers. All right. Okay, so I do not have any financial disclosure. So this is what you should do as a glance. So first of all, visual acuity. Okay, you should check the visual acuity before any intervention. However, you have to bear in mind that you have to take notes of any immediately life-threatening or vision-threatening condition. So for example, if a patient come to you with a posterior reversible encephalopathy syndrome, where the patient have a blurring of vision, but at the same time also the blood pressure is very high, so you should treat the blood pressure first rather than checking the visual acuity. Okay. Similarly goes to the patient who have acute onset of any visual field, especially those that respect the very vertical meridian, such as homogeneous hemianopia, homogeneous chondrodropia that acutely occur. These are the patient that you are think of whether the patient have any stroke, be it ischemic or hemorrhagic. So usually this kind of patient that have for example, a high BP or high CBS, then you need to stabilize the patient first, then only check the visual acuity. Next thing about this visual acuity is you have to use the proper term to describe the visual acuity of the patients. For example, the 660, the proper term that we use, because it's very important for us to document and also to communicate when you want to make a referral. Okay, it's also for your own documentation as well. Okay, so of course, in overseas, sometimes you see the 20 over 200, 20 over 20. Okay, this the unit that they use is the foot, but the 616, the unit that we use is the meters. Okay, so actually it's pretty much the same, just the unit to measure is different. Okay, next is the eye examination. Okay, because you are the frontliners, so actually you are very important in terms of our health facilities, and of course, in terms of reduce our burden in treating the patients before making a referral to us. So actually, there are a lot of things that you can do. In terms of ophthalmology, of course, you can do a proper structured eye assessment. Okay, apart from the visual acuity that we mentioned just now, there's also a pupillary examination where you need to check whether the pupil is dilated or is irregular. And of course, regarding the RAPD, especially when the patient presented to you with a blurring of vision. Next is the confrontation. Confrontation is something you can check to detect whether it's a visual field defect. Okay, especially those patients that has a visual defect that respect the vertical meridian, such as the homogeneous chondrodropia, homogeneous hemianopia. These are the lesions that is localized posterior to the optic chiasm. It means it's intracranial, so you need to refer to us, especially if they happen acutely. So you need to suspect anything that is vascular in origin, for example, ischemic stroke or hemorrhagic stroke. If that happen over sometimes, it may be a space accumulation such as a tumor. All right. If the patient has a bitemporal hemianopia, then you have to think of lesions that compressing localized to the optic chiasm, such as the craniopharyngioma. Okay. Next is the extraocular muscle movement. Okay, in the extraocular muscle movement, also is important because if the patient has sudden onset of any diplopia, so you need to identify whether the patient has any nerve palsy or not. For example, in the sixth nerve palsy, and also third nerve palsy, there's a common nerve that be involved. And in fact, there are nerves that control our eye ocular movement. Also, it can happen to kids. You don't be surprised if the patient, if the kids having used too much near gadget over a short period of time. Not too long duration. Okay, so the patient can have a acute acquired esotropia. Okay, it may not be a sixth nerve palsy, but it is one of the indication that you might consider to do a CT scan. okay, just to look for any intracranial pathology. Not a must, but you have to suspect that. Okay. Then we have an anterior segment examination. Anterior segment examination, of course, the proper one, you should have a slit lamp, but I guess most of you do not have a slit lamp in your clinic or your premise. But you can try to do as much as possible because there are something that you can see through your naked eyes. For example, in the photos over the right side, as you can see in the first photo, there is a hypopyon. There's an accumulation of the pus in the anterior chamber. Okay, it may signify a uveitis or be the infection in origin or inflammatory in origin. Okay, and then you can look at this, the middle photo, there's a lot of keratic precipitates over the cornea endothelium. Of course, if the the keratic precipitate is too small, too tiny, you may not be able to see with your naked eyes. However, if it is this big, what we call as a mutton fat KB, yes, you are definitely able to identify, and it is also some signs of a uveitis. Then you can see there is a irregular shape of the pupil. Okay, this is due to posterior synechiae, which is the adhesion in between the iris and also the anterior capsule of the lens. Okay, this also signify a uveitis. Okay, can be a inflammatory or infection in origin. Okay. If a patient come to you with a red eye, with a headache, nausea, vomiting, and you suspect acute angle closure, okay, this is what happens where the angle of the anterior chamber become very narrow or even closed. Okay, but you do not have a slit lamp in your clinic or premise. Okay, this is what it should be lah. Okay, but you do not have that. So what you can do is you can use a torchlight. Okay, use a torchlight to shine from the temporal side. Shine from the temporal side and look at the illumination of the whole iris. Okay, how much you can see. If you have a normal angle, which is deep, okay, by right, if you shine the light from the temporal, you are able to illuminate the whole iris, okay, because there's no any blockage. Compared to if the anterior chamber become narrow or shallow, okay, when you shine the light from temporal, okay, the light cannot illuminate the opposite side, which is the nasal part, because the light has been blocked by the iris that move forward now because there is a shallow anterior chamber. Okay, this is what you can do. Okay, especially if the patient come to you a red eye, a headache, nausea, vomiting, which indicates they may have a high intraocular pressure. And with this one, yes, there is very much likely to be a acute angle closure, and you need to refer to us immediately. Okay, because a prolonged duration of high IOP can cause a damage to the optic nerve. Okay, next is irrigation. I think this one has been elaborated by Prof. Azani just now. Okay, so if you have any patient with chemical injury, just do the irrigation. Okay, do not take history. Just do the irrigation. Okay, because you know, especially the alkaline, it can penetrate the ocular structures very fast. Okay. And then what's the copious amount of normal saline? Is at least 2 liters. Okay, 2 liters and over 20 to 30 minutes. And of course, you have litmus paper. Please check the pH. You have to continue the irrigation even though already finished the 2 liters, but the pH is still, for example, acidic or alkaline. Okay, you have to keep on do the irrigation until the pH normalize. Okay, this is very important. And do not forget to flip up the eyelid, because sometimes the chemicals can hidden within the fornix, okay, which is the inner part of the eyelid. Okay, so you need to flip and do the irrigation properly. Okay, then we have a fluorescent stain. Okay, like what Dr. Ayn just now mentioned, not all red eyes are conjunctivitis. Okay, there are far more than that, and I think Dr. Ayn has given a very good coverage on that. And you need to do a fluorescent stain. Okay, if you have that, okay, because it helps to detect the corneal abrasion, corneal ulcers, dendrites, or dry eyes. Okay, sometimes if the corneal abrasion is not that big and they do not have any surrounding edema in the cornea, it may not be that easy to see. Okay, because anyhow it's transparent. Okay, So you need to use this fluorescent stain to delineate, to help you to better visualize the epithelial defect, or in other words, the corneal abrasion. Okay, because in a healthy cornea, the epithelium is bound together by a very tight junction, and they are not supposed to pick up any stain. Only when the epithelium breach, then the stain will be taken up. Okay, so it's very important. If you can do that, it's very good. Then also we have this dendrites in the patient with hepatic eye disease. Okay, it form a lot of dendrites. Okay, so you just treat with for example, the choromphalangeal as a conjunctivitis, so it will not heal. It will not heal. Okay, because you do not treat the underlying cause. Then we have empirical treatment. Okay, this is what you can help us. For example, you have a patient that you're very confident there is a conjunctivitis in the first presentation. Okay, then you can treat it with a choromphalangeal, be it a gut or ointment. Or a very small corneal abrasion, yes, you also can treat that. Of course, if the patient has a prolonged duration, not getting better, usually a conjunctivitis will heal within 1 week plus to max 2 weeks. Okay, then anything beyond that, then you have to refer to us because sometimes we might think need to escalate the antibiotics, or there are other underlying causes. Okay. Then, like what Prof. Azin said just now, you need to put eye shield rather than a patch. Do not patch, okay? Do not pat or do not patch, okay? Either one also cannot. So you should do an eye shield. If you do not have an eye shield, you can do a modification either with the bottom part of the nasal line, so a normal saline water, or you can use the bandage to create a donut and paste on it. Okay, basically what we want to prevent is further injury. Okay, I have a patient a few years ago where he go to fishing with his friend, and when his friend cast the fishing rope, and then the nail hit on his eyes. Okay, it came in without any eye shield, and then there is of course, there's an entry wound, and then there's more than one exit wound. Okay, because there's no any protection be done. Okay, of course, if the wound is lying at the peripheral part and we suture it with a good outcome, maybe the patient will more or less feel like some astigmatism, glaring. Okay, but if the wound lies right within the visual axis, then the patient will have blurring of vision forever in their life. Okay, because it's not something can be corrected by prescription glasses. So we really need to protect that from leading to further injury. Okay, especially in the patient with penetrating or group rupture. So shield the eye, not patch, not pack. Okay. Then systemic history is very important. Okay, as what Dr. Aiman mentioned just now, the diabetes mellitus, there are a lot of disease, okay, related to DM. Okay, one of them, of course, is the diabetic retinopathy. Okay, in a mild form can be a mild NPDR, moderate, severe, and then we have the proliferative diabetic retinopathy, and even worse, it leads to the ADED, tractional retinal detachment. Okay, then hypertension can lead to hypertensive retinopathy. Autoimmune disease can cause, for example, the vasculitis, which can cause a nerve palsy. Okay, in the eye itself, it can cause uveitis. Okay, for example, the patient with rheumatoid arthritis, the systemic lupus erythematosus. Okay, then any recent infection. Very important in our population is the tuberculosis. Okay, tuberculosis and also syphilis. These are two infections that you really need to put how to say need to be aware of lah, because both of them, especially the syphilis, they can mimic any type of uveitis. Basically, any type of uveitis can be both of them, especially syphilis, and syphilis can be any type of the uveitis as well. Okay, regardless of the patient say do not do this and do that, but you really need to suspect okay, this is something very common. Okay, then any medication the patient takes, especially as steroid, okay, which can lead to high intraocular pressure in the long run. Of course, it's not as potent as the topical, but still there's a risk. And then you need to do a timely referrals. Okay. For example, the corneal ulcer keratitis, this type of disease, the chloramphenicol is just not enough lah. We may need to add on gentamicin, okay, ceftazidime, okay. Or maybe it's a fungal ulcer, then you need to do you need to give antifungal such as the amphotericin B, fluconazole. Okay, then your uveitis. Uveitis, usually we need to investigate. Okay, unless it's a very mild, just a first episode, unilateral eye. Okay, but usually we need to investigate because uveitis itself is a very big topic. In fact, the uveitis itself is a subspecialty. Okay, so it's a very big topic, and we need to do investigation and see what is really the underlying causes. If not, we are just treating the symptoms rather than the cause. Okay, then acute glaucoma, for example, the acute angle closure, you really need to refer to us immediately, okay? Because we need to bring down the intraocular pressure fast to prevent any further damage to the optic nerve. Then orbital cellulitis, okay, orbital cellulitis means the ocular itself, the extraocular muscles, okay, even the optic nerve has been involved. So it's really an emergency, and we need to do imaging because we want to know what is the extent of the disease, whether there's any pus formation in the subperiosteal area, or even further progress into the cavernous sinus thrombosis, or even an intracranial spread. Okay, so it's an emergency. Any patient with a sudden vision drop, for example, if a CRAO, the central retinal artery occlusion, okay, there's a windows, okay, there's a windows of treatment. We need to do something, okay, to try to dislodge. For example, you do the ocular massage, we do the carbogen, and what's that? And also maybe we do a paracentesis. Basically, all these things we want to bring down the intraocular pressure fast and try to dislodge the emboli to more the distal branches. Okay, all these things we need to do in the hospital. Okay, so please refer to us fast. Okay, then any trauma, especially we told a suspected structural injury. Okay, for example, in the corneal laceration, this thing definitely need a surgical treatment. Okay, and we need to repair fast because the iris tissue that is exposed to the environment, there is a duration where it can stay viable. Okay, if it is too long, the iris tissue will not be able to stay viable and become necrotic and cause an infection. It become nidus for infection, and also inflammation. Okay, we have talked about the do's. Now we are moving towards the don'ts. Okay, so number one, very, very important is please do not prescribe topical steroids without ophthalmology input. Okay, this is very important because they do not just may worsen the hepatic eye disease, the fungal keratitis, or mask any serious infections. Okay, if the patient has for example, the lymphoma in the eye, what we call as a primary CNS lymphoma or primary vitreoretinal lymphoma, it's a very typical history where the patient is prescribed with topical steroids and it improves temporarily for a while. But after that, it becomes worsening. This is very typical history of the PCNSL or PVRL, the lymphoma in the eyes. Okay. On top of that, steroids also can cause increased IOP or leads to glaucoma. Okay, for information, there are about 1/3 of the population is the steroid responders, which means every 10 patients you prescribe with the topical steroids, 3 to 4 of them will have a high IOP, and around less than 10%, around maybe one of them will have they are high responder, which means there's severe increase in the intraocular pressure. Okay. So, of course, topical steroid is the most potent in terms of causing a high intraocular pressure compared to a periocular, systemic, or oral, or the steroid cream applied to the skin. So, please do not prescribe topical steroids without ophthalmology input. Okay, that is very important. Okay, the below photo one is the dendrites in the hepatic eye disease. The right hand side is the fungal keratitis or fungal cornea ulcer. Okay, as you can see, there's an infiltrate over the cornea, a multiple weight with a satellite lesion. Also, there is a hypopyon formation, which is the pus accumulation in the anterior chamber. Then topical anesthesia. Okay, do not prescribe topical anesthesia for home use. Okay. In fact, even in our ophthalmology setting, we do not prescribe topical anesthesia because it may mask the underlying discomfort and delay the timing for the patient to seek for treatment. That is not good. Okay. The topical anesthesia also may delay the healing or reduce corneal sensation and cause a corneal epithelial defects in the long run. So do not prescribe topical anesthesia. Of course, artificial tears is a very commonly used drugs. Okay. And so many people are using and is widely available here and there. Okay. However, you need to bear in mind that if the topical artificial tears have a preservatives, okay, you cannot prescribe too frequently. The maximum frequency as suggested is 4 times per day. If you need more than that, beyond this frequency, you need to change to those without preservative. Okay. Yeah, of course, they are much more pricey than the one with preservative, but you do not want to cause any further damage because they contain this benzalkonium chloride, or we call it a BAK, that acts as a preservative. Okay, this is actually it can actually cause a toxicity if they are frequently used. They cause a toxicity to the cornea epithelium, to the conjunctiva, okay, and leads to irritation and inflammations, and of course the worsening of the cornea epithelial defects. So you may find it weird. Okay, the artificial tears is a drug to treat a dry eye, but in return, if you use it too frequently, it can worsen the dry eye. Okay, this is because of the content of this BAK, the benzalkonium chloride. Okay, so please bear in mind the maximum duration you can give is 4 times per day. If you need more frequent than that, please change to the one without preservatives. Okay, then red flags. Do not miss any red flags. If a patient have a pain with photophobia, okay, they may not be just astigmatism. Okay, there may be a anterior chamber cells in the uveitis that leads to this photophobia. If the patient with a red eye, pain, halos, it may be signs of the acute angular closure, because in acute angular closure, the IOP is very high. There's a decompensation of the cornea endothelial pump and leads to cornea swelling, cornea haziness. And this is what the reason of these halos. Okay, then decreased vision, especially those a sudden massive drop, please do not miss it. Then irregular pupils may be the procedure synechiae, like what we mentioned just now. Then any corneal opacity, it may be a corneal ulcer, be the fungal, bacteria, doesn't matter, but it may be a corneal ulcer. Okay, it may be the infiltrate of the ulcer. Then RAPD especially is positive. Okay, if a patient have a blunt trauma, for example, there's no any injury. Okay, there's no any laceration, wound, or abrasion, just a blunt injury, but the patient has a drop in the vision, and during our assessment, RAPD is positive. So this is likely to be a traumatic optic neuropathy, and you need to refer to us because we need to start the IV methylprednisolone. Okay, there's also a window of treatment for this. Okay, then any proptosis, it may be there may be an infection or any lesion or any mass behind the eyeball, right, and etc. If the patient have a red eye with headache or nausea, vomiting, it may signify signs of a increased ICP. Increased intraocular pressure. Okay. Then patient with a vision drop, with a headache, scalp tenderness, especially in elderly more than 70 years old, you need to suspect whether it is a giant cell arthritis or not. Okay. Then red eyes, like what I mentioned just now, not all red eyes are conjunctivitis. So please do not assume this. Okay, there are far more than that. There are corneal ulcer, keratitis, acute angular closure, uveitis, foreign body, chemical injury, and etc. Okay. Of course, you are very confident, then you are very sure this is conjunctivitis, first episode, then okay lah. Then next is the foreign body. Okay, do not remove any penetrating or deeply embedded foreign bodies. Preferably, we need to remove it under the slit lamp because we need to know how deep the foreign body embedded into the cornea. If it is very deep, we cannot remove under the slit lamp. We need to remove in the OT because we need to anticipate whether we need to do the TNS or not. just in case if it is too deep and it cause a aqueous outflow, leaking, okay, then we need to do a cornea TNS. Okay, you need to put an eye shield. Once again, eye shield, not patch, not pad. Okay, and then refer to us. As you can see in this first photo, okay, there is a metal dust. Okay, this is very common. As far as I can remember, I don't think during my MO times, I don't think any on-call I do not encounter this foreign body. This is so common. So common. Okay. Because a lot of people that do the work, for example, grinding the metal, cutting the metal, they do not wear any eye shield. Okay. So it's very common. Then in the second photo, you see, okay, there's a branches. Okay. If you pad, you push the branches further into the eye and it may damage the iris, damage the lens, okay, breach the capsule and leading to more complication. Okay. And this one also in the there's a metal wire. Okay. We need to remove in the OT, this one, definitely. Okay. Because we need to do cornea TNS and we need to assess whether it is so deep and penetrated through the lens and cause any problem to the posterior segment. Okay. In the vitreous, in the retina, even the choroid. Okay. So then next is the contact lens. Okay, if you have a patient with cornea ulcer or keratitis that is related to the contact lens, for example, the patient wearing a contact lens and swimming in the ponds away, okay, we must suspect there is a pseudomonas or acanthamoeba. So please do not throw it away. Including the contact lens and also the cartridge, okay? Because sometimes we need to send to our microbiology colleague for assessment and do the culture and sensitivity to identify what is the real microorganism that caused the keratitis, okay? Yeah, some hospital they do not do CNS on the cartridge, but you just keep and ask the patient to bring to us, okay? No harm, okay? Then for the reassurance, do not over reassure, okay? You do not over reassure without any safety netting. Okay, you have to advise the patient to return, especially in the symptoms worsening, not resolving, persistent, and any drop in the vision or there is new symptoms. Okay, for example, in a patient in a conjunctivitis or bacterial conjunctivitis, yeah, it may heal. It may heal after 1 and 2 weeks like that, but subsequently the patient tells you they have a blurring of vision, they have glaring. Yeah, in this kind of condition, you may suspect there is actually a pneumonar keratitis, and which is a hypersensitivity towards the bacterial antigen. And this one we need to start steroid. Okay, we need to start steroid. Of course, before that we need to measure the intraocular pressure, and of course we need to monitor the IOP after we start the steroid. So you need to refer to us. Okay. So I think this is my last slide. With that, I thank you.
If the child has strabismus due to history of prolonged use of video games, like what mentioned during the presentation, can we just advise for monitoring and stop video game exposure or refer Opthal?
Okay. Thank you for this question. I think this is very much related to me because I'm in the PITS team for Opthal. Okay, if you have a patient, you have to refer to us because yeah, likely is because of the prolonged usage of the near gadget. But how 100% sure are you that is not the other things, right? Okay. Usually, if the patient have an acute onset of esotropia, which means the eye move inwards, okay, usually we may consider to do a imaging just to make sure there is no any underlying intracranial pathology. Okay, so you refer to us, and then apart from the avoid near gadget, we also need to monitor. Okay, we also need to monitor the patient and we need to measure the angle deviation. Okay, if the patient do not resolve, we will consider to do a screen surgery okay, we would do a surgery to relax the media rectus, okay, which is the eye, so which is the ocular muscle that bring the eye inwards. Okay.
How to approach dry eye cases?
Right eye.
Dry eye cases.
Okay. In terms of dry eyes, okay, you can if you have the fluorescence, Okay, you have fluorescent, you stand and you ask the patient to blink and open the eye. Close the eye and open the eye and stay there. Okay, supposedly it should last more than 15 seconds. If it is less than that, okay, is the quality of the dry eye is not good. Okay, this is number one. Two, you can look at the this with your setting huh? You can look at the pooling of the tears. Okay, if it's too little, then the protection is not enough. Three, you can stain the cornea and look at the any punctate epithelial defect or not. This is also a signs of dry eyes. Okay, if the tears cannot stay at the cornea long enough, this is the quality problem. Okay, if the pooling of the tears at the inferior fornix is not good enough, it is the quantity problem. Okay, can we give CMC?
Child less than 2 years old.
Okay, yeah, this is a very good question. Supposedly you shouldn't but because there is a problem with gray baby syndrome. Okay, supposedly you shouldn't, but 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 I don't think you have other like I'm not sure whether you have other yeah. I'm not sure you have the what Silosan or Fusitamig or not. If you have, you can give that. Okay. Okay, usually here lah. I'm not sure about outside practice. Usually here is 2 years and above lah.
In viral conjunctivitis, if it is viral and self-limiting nature, should topical antibiotics be prescribed?
Okay, usually I will prescribe. Personal practice, I will prescribe because we want to prevent the secondary bacterial infection. But maybe not as frequent as the bacterial conjunctivitis, but I will still prescribe. And of course, I will also prescribe artificial tears preservative-free because it can help to flush away any debris and also the viral load. Okay, and also provide comfort to the patients.
Thank you for the reply. For recommendation on method of removing foreign body, as far as the doctor know, we have been using arcane and removing it via back of needle.
The question is?
The recommendation to remove foreign body.
What is the okay? There is no hard and fast rule say which instrument you must use lah. Okay, but here we usually use a needle. Okay, not back of the needle. We use a needle lah because the needle how to say the what is that, the head of the needle, the belakang, the back part, this is too big lah. I don't think you can remove. So the tip of the needle, yes, because it's sharp and it's sterile. Okay, this is what we usually do lah. Yes, under the slit lamp. That's why we recommend you to refer to us because we really need to know how deeply embedded the foreign body is. If it's too deep, we want remove under the slit lamp. We need to remove in the OT if it is very deeply embedded, and even more so if we already saw is a fully penetrating. Okay.
Less than 1 year.
Less than 1 year, less than 2 years, basically it's the same. It's just a option of antibiotics.
If a child complains of myopia, do all of them need to refer Opthal or is there any age limit?
Okay, if the patient has myopia, you are very sure it's myopia, right? So you check the visual acuity. Okay, then you use a pinhole. If the patient has myopia, the pinhole should improve the vision. Okay. Then next, you can ask the patient to go to the optometrist to have a check. If the optometrist they think it need to refer to us, then they refer to us. For example, a very high myop, or there is a fast progression of myopia. Okay, these are the patients they will refer to us. Then we will investigate and do the necessary. For example, whether we want to start a myopic control, either with a peripheral defocus glasses, or you want to give a low dose atropine. Again, there is the possible treatment, okay, for myopia. And of course, for you can also help us lah. You can ask the patient to increase outdoor activities and reduce the usage of near gadget. Okay, it's not by me, it's by a proper study worldwide. Okay.
Is it beneficial beneficial to send swab CNS for most conjunctivitis cases?
Not really lah, not really, not really. Okay, if we think necessary, then we will send. Okay.
The right to check for vision acuity in the suspected chemical foreign body before or after?
After, definitely after. After you do the irrigation. Okay. You do the irrigation, you got a litmus paper, you check the pH, it is already neutralized, then check the visual acuity.
Few patients develop eye lid swelling post CNC for conjunctivitis. Okay, I know is it common to develop allergic post CNC?
Okay lah, I have not to say many lah, over these years CMC I give quite a lot already lah. But maybe less than 3 again. Yeah. So we will change to the other antibiotic, for example, ciprofloxacin. Okay. But you have to make sure, number one, this is not the worsening of the conjunctivitis into preceptor cellulitis. If that is the case, we need to how to say, we need to give a oral antibiotic such as the Augmentin, or even worse, then we need to give a IV lah. Mana ni? Okay, hello.
For long,
Mana?
it's under track A checkbox yang another checkbox.
Oh, okay, double. Okay, what's the question?
On prolonged intranasal corticosteroid, for example, treatment for allergic rhinitis, is there any need to have IOP monitoring? And how about if the patient has family history of glaucoma?
Okay. According to the potency and risk lah, okay, the intranasal steroid is pretty much down the line, okay, compared to, first, of course, is the topical, then followed by periocular, then systemic, then only the intranasal. Okay. But if the patient has a family history of glaucoma, or the patient itself has symptoms, okay, it's better to have a check on the IOP lah. Can we remove?
Okay, can we remove pseudomembrane?
Okay, if you are confident, you can remove. Okay, but I bear in mind, you have to tell the parents there is a risk of bleeding because the membrane is adhere firmly.
Sorry.
It adhere firmly to the inflamed palpebral conjunctiva. Okay, sometimes it cause a serious hemoserous bleed. Okay.
If in diabetic retinopathy, for example, in patients with mild to moderate NPDR, can fenofibrate be added? And if the patient has underlying dyslipidemia, but their LDL cholesterol is already well controlled with stain?
Usually the copious amount is 2 liters lah. Okay. So far, because of this thing, I never stop irrigation after 1 liter. Usually I check after 2 liters. Okay. But I cannot give you a definite answer for that. But what I tell you is my practice lah, and what is the definition of the copious amount of irrigation. Okay.
That's all for the question until yang fenofibrate.
Assalamualaikum. So for basically for question that mild moderate NPDR, Yes, fenofibrate had a very good percentage to reduce progression of diabetic retinopathy, and will reduce the need for first laser treatment. But if it is well controlled, I think need to co-manage with medical team if you are planning to start to combine statin and fenofibrate. Thank you.
Thank you everyone for asking lots of and questions and doubts for this webinar. We are going to move forward to our last session, which is the Kahoot session. So get ready with your gadget, as there will be prizes that you can win. First winner is RM 300, second winner is RM 200, and last winner, third winner is going to be RM 100 ringgit. So get ready with your gadget, and we will show you our QR scan. Okay? Hi, we will give about another 5 minutes for everyone to enter the Kahoot session. Yeah. Okay, we will start, yeah?
Nanti
Hello, regarding okay. Okay, sorry. Regarding the question on how to differentiate whether it's conjunctivitis, keratitis, and uveitis. Okay, for the conjunctivitis, you have to know the anatomical that implies by its name. Okay, conjunctivitis means there is a engorgement and dilatation of the conjunctival vessels, which will give rise to you a red eye. Okay. But it's not like the subconjunctival hemorrhage where there's a homogeneous reddish color. Okay. It's at the conjunctiva. Okay. Next is the keratitis. Kerato means a cornea. It means the cornea has been involved. Either there's a infiltrates. Okay. Multiple infiltrates. Okay. They also may have a epithelial defect. Basically, there's an infiltrate. Okay. And they may have a surrounding cornea edema. Okay. So the keywords here is the infiltration on the cornea. Sorry, in the cornea. Okay. Then regarding a uveitis, uveitis is the inflammation of the uvea tissue, be it due to the inflammatory process or due to the infectious disease. Okay. So what you can see with your naked eye is if there is a large enough keratic precipitates, like what I showed you just now, is a precipitation on the cornea endothelium, means the inner side of the cornea. Okay. That is the signs, one of the signs of uveitis. Next is like a hypobion, which is the parts accumulation in the anterior chamber, and like the posterior which is the adhesion in between the iris and also the anterior part of the lens capsule. Okay, these are the things that signifies a uveitis. So you have to know what the structures involved according to the names implies. All right.